So this is our May 6th Affiliate Connections call. I'm Lane Kenny. I'm Director of Industry Relations. And we have a couple of special guests on the call here today. So we'll be doing some introductory material, just reviewing some of the resources that we have available to you on the site. A couple of weeks ago, we held this call and we had an opportunity for a lot of you to share with us some of your questions and concerns. A lot of those questions and concerns were really related around, will we be seeing a second surge? What are some of the best practices we're seeing out in the industry related to response, cleaning, setting up, or kind of how do we get back to taking units that have been used for COVID patients and making them safe for acute care again. So what we did is we've gone out to the industry, and we have Robert Booth here today. He is a subject matter expert and infection preventionist, and he'll join us for a discussion, and he'll be addressing all of the questions that we had on that last call. And he'll be sharing some additional information with us around some of the task force and committees that he's involved with. And then we'll open it up for Q&A at the end. And what I'd ask is that you just put your phones on mute and use the chat box to ask any questions, and we'll answer as many questions as we can. I think we're going to have a pretty big group on the line here today, and I'm really happy to see so many people taking the time to learn from the experiences that Bob has had. And he actually has some of his industry friends here with us as well to share their experiences from the front lines. So just a couple of recommendations. Just close any unnecessary windows on your computer. This session isn't going to be quite as interactive as the last one we had, so whether you'd like to leave your camera on or not is optional. And then if the audio isn't working well for you, in the meeting invite, there's also a phone number, so you could call in. And then the call will be recorded, and you'll be able to access it on the members only page on the center's website. And then to optimize the view so that you can see the screen as well as the speaker, you see that there is this little menu at the top of the screen. And if you pull down on the view options and choose the side-by-side mode, that will allow you to see the presentation slides. And then on the right-hand panel, you'll see the speakers and the attendees. It shows you how to get to the members only page. So you go to the About Our Members section on the website, and then in this box on the right, you see the Affiliate Members Only page, which has recordings of all of the previous Affiliate Connections calls, along with all of your member benefits. So it's a really useful page. The Center for Health Design has created their COVID-19 resources page, and this page has a lot of resources, tools, research that is actually still being peer reviewed, but is very timely and relevant. And it also provides access to the Center for Health Design Infection Control Toolbox. So I encourage you to make note of that and take advantage of all the resources. A couple of highlights of the types of resources that are available in the Infection Control Toolbox include something like, and there are probably 30 resources total, but there's an issue brief that covers contact transmission, the role of surfaces in healthcare associated infections. And you can see it's a very interactive piece. So this might be something to share across, the multidisciplinary team. Certainly a great learning tool. And then Ritali Joshi, maybe about a month or two ago, probably 3 months ago now, she is a research intern at Hunter University. We did a research project on combating healthcare associated infections, and really looked at the design of surfaces, the choice of materials, and cleaning mechanisms. And this was a fantastic study that she did, and you can access that on the members only page as well. And so, as I mentioned, we have a special guest here today, Bob Booth, and he's going to talk about COVID-19 infection control and facilities risk, looking at it from a recovery and planning perspective. And as I mentioned, he is an infection control preventionist, an industrial hygienist with Encore. And we're really appreciative that he took some time to spend with us here today. He's very involved in the industry. These are a few of the task forces that he is contributing to at the moment. So I don't know how you have enough time to do all this, Bob, but we're glad that you're doing it.
Thank you.
I'm going to hand it off to you, Bob. If I missed anything, you can play. Thank you so much.
Great, thanks, Lynn. I talked to Lynn a week or so ago at another meeting and was telling her some of the committees that we are starting to formulate ideas about. Some may think it's too early to do that. I don't think it is. I mean, depending on what you think about planning, we should always be planning ahead. One of my favorite sayings is here from the past HHS secretary, which is everything we do before a pandemic will seem alarmist and everything after will be inadequate. This will be my fourth pandemic to be through. I've been through H1N1. I've been through MERS and SARS. I was working in Korea at the time when MERS was significantly outbreak of MERS in some of the Korean hospitals. We'll talk about that. And H1N1 in New York and in Florida, I was a infection control practitioner doing that reporting. Next slide. What we're going to go over today basically is looking at, I think we should start off by looking at some notable pandemic information so that we could use that to guide ourselves forward for what our thinking should be. This presentation is going to be forward thinking only. My audience, when I put audience assumptions up there, I assume that everyone knows that we're in a pandemic. You've been reading the news, you know that there's efforts out there. We're not going to look back to whether this was something that could have been addressed earlier. That's not the purpose. Our groups have been getting together, and there's been many groups. I'm not involved with all of them. I'm only involved with a few, as to what we should be doing and thinking about in the future, mainly because it's going to be upon us over the summer, and are we going to have another issue in the fall? So I want to look at some notable pandemics just to give us some ideas of things that we should consider, what we've learned, where we are at today, recovery planning, and then some very notable reference materials I put in the presentation for you to consider and look at, because it's something that you really should consider, and some of the planning information that's been out there is very valuable. We'll talk about CDC information, South Korea CDC, the WHO guidelines, CMS, ASHE, and the New York Department of Health. Next slide. So history, I've heard a lot of my colleagues and students and others talk about the great Spanish flu of 1918 in graduate school and in our training. I'm master's trained in infectious diseases, have a degree in epidemiology, and we studied the 1918 flu, and I hear a lot of reference to that as to what we think is comparable to what we're going to, and I will disagree with that, and I'll tell you why in a minute. We've had other pandemics, and this is not all of them. I didn't put in the Asian flu, which was very significant back in the 50s. But we had the Hong Kong flu in 1968. We've had SARS in 2002, H1N1, which H1N1 is the same as what caused the Spanish flu, and it didn't occur in Spain. It was just named the Spanish flu in 1918. And then MERS, and then now COVID-19. Interesting, if the group is not clinical, the disease is COVID-19. The actual virus that causes COVID-19 is SARS-CoV-2, which we saw start to get back in the community at the end of 2019. So that's what we test for. So we can look at SARS, although SARS, as you've heard and seen in the literature, kind of fizzled out. We didn't have very many deaths with SARS in the US, but we basically did have a lot of history here that we can look at and make a determination of where we go and what kind of things that we should be considering. Now, why do I think the 1918 flu is not comparable? Is because that's really pre-vaccination process. We didn't have a vaccine back in 1918. We didn't really start getting vaccines until after the Asian flu in 1956, and that vaccine was developed in late 1957. There was a significant amount of deaths. However, that vaccine was made available. We currently have no vaccine for SARS, which is a COVID virus. We have a vaccine for H1N1 because we're studying that for years and years. And that vaccine, I'm going to use that as an example because I kind of think that we're going that route as to preparation. What we've seen is really the most significant pandemic or outbreak that we've seen in the last 10 years. We have a vaccine for that. We don't have a vaccine for MERS, and obviously we don't have one for COVID-19, which is what we're all hoping for. So next slide. The history is really kind of significantly mimicking what we're going through now. This is an interesting photo from the Hong Kong flu back in 1968, and I was a young child back then. I don't remember this. However, I can remember my mother speaking of it and the worry that our parents had in our hospitals with social distancing and masking and trying to limit patients from exposure to this virus. Our most significant risk category right now, if you aren't aware, our elderly population. Our patients that are in nursing homes are at highest risk. We're currently seeing a high rate of mortality in our nursing home patients. 25% of deaths in New York have been in nursing homes. And so it's very significant, and we're trying to prevent our risk of exposure. So our infection control practices of social distancing and limiting contacts is very significantly improving the situation, but we need to go forward and think, what's going to happen? And I can't tell you that. And I don't think any of us can. We all hope for the best. We all hope that something doesn't happen over the summer or the fall, but until we get a vaccine, history has shown that it's going to, or it could. So we need to be aware, and that's what this forward thinking of preparing and not letting our guard down and what we should do, all the organizations that we're going to talk about. And I'm not going to go through all the precautions and all the things that you should consider. I'm going to give you those references because a lot of thought has come into that. There's the American Hospital Association, ASHE, CMS, CDC have all put out guidance that we should consider. Next slide, please. So as a reference, just to kind of get the idea here of where we're at, I will use H1N1 because that's the one that I was involved with as an infection control practitioner back in 2009. Our first case was discovered, this virus came from Mexico, but it was first discovered in California in April. And look at this timeline. This timeline is totally different than what we have now. The WHO declared it an epidemic or a pandemic within a short period of time. The FDA approved testing guidelines in a short period of time, April 28th. Next slide. And then we had testing available May 1st. So this is kind of the same timeline we are now. We have some testing available, but not readily available as we really think. And if you talk to people around the country and around the world, that testing is still not readily available how we want it. Testing was back in H1N1. I reported many cases to the health department during this time frame. June, summer camps were canceled. Cases doubled. There were three virulent strains that were detected in other countries. And, you know, this just kind of shows a timeline of where we're at and what we may want to consider as a model to look at, to hope that doesn't happen, but it could. Next, please. In August, the CDC put out guidance, and there's guidance from the CDC now for businesses of reopening and what they should do. Then we saw a second phase or second wave of H1N1 that came out in early fall 2009. The first doses of vaccine were delivered and made available to the public in late October. Next slide, please. And then we started setting up vaccination clinics. And by January, activity had really dropped. So the point to be made here, if we look at history, and we can't just guess, and we want to make a educated decision, everything I'm trying to give to you is factual. It's not my opinion, is that we really need to wait till we get a vaccine before we put our guard down. And so in our field of infection control and public health, we want to make sure, based on history, that we have that available and we do everything we can to prevent transmission and ongoing issues. So next slide, please. So what have we really been doing up to the point where, like you see in this slide, this is in a vaccination clinic set up in a it looks like a movie theater in San Francisco. What are we going to do when we do have a vaccine available? And this forward thinking of, okay, and I saw some of the questions that were submitted. What are we going to do with our equipment? What are we doing when we shut down our COVID units? Well, what are we going to do when we have testing more readily available and we have better idea of where the vaccine is going to be administered? These are things we have thought about for years during our pandemic planning, okay? So those are, so, when Lynn asked me to introduce and talk about this, this subject and what some of our committees have been talking about and doing, we've been getting many, many questions, as Lynn had mentioned, about what happens when we take a unit and turn it back over. That's been discussed in the ASHE 170 and other ASHE committee groups and in the ASHE groups. What do we do for planning forward? And so I thought I'd give a good overview of what we've seen in the past, which is some of these notable pandemics and what we can consider, based on past history and, human nature and what happens. The peaks of these could happen again in the fall. If you look at the Asian flu in 1956, there was a peak in October after schools opened back up. We hope for social distancing and contact precautions of not, spreading disease, but sometimes it just doesn't work as we planned. So our planning has to address that in that fashion. So next slide, please. So where are we at today, May 6, 2020? Some states are reopening in different phases. There have been protocols and guidance put out from different states. I'm in the state of Florida, where the guidance is put out for 3 different phases. We are in phase 1. The beaches are open in some areas. Restaurants are open to 25% capacity. Other areas are opening based on criteria that has been published from the state as to if you see a decline and what types of infections you're seeing in your community. Are we following that to the T? I have no idea what we're doing. All we know is we're opening in different phases at this time. There are still some stay-at-home orders throughout the country. There is currently no vaccination or treatment that's been approved. We're seeing other infections in our patients. We're seeing what we historically see, bacterial infections, pneumonias, in our patients that are on on ventilators and have been, very ill. We're seeing different types of things that we are being overwhelmed with. The method for widespread testing is still not available. There's guidance. Each state has their own guidance. It's not readily available, in my opinion. If you talk to people in different parts of the country, they'll tell you the same thing. In some state areas, maybe it is available, but it's not concrete. This time frame of May 6th, where we would expect it to have better testing, we're just not there yet comparable to the H1N1, where we had testing available a little bit more readily. Supplies and PPE, personal protective equipment, appears adequate in some areas of the country. Some it doesn't. That's just the fact. Ventilators are being provided, and we've always heard about ventilators. Ventilators need to be available. This is one of those where I can think back when we were planning for a pandemic. Wow, we're going to have all of these ventilators. I don't know if that's really necessary, or maybe it is. Well, guess what? It is. We've had a lot of patients on ventilators, and the worrisome part of that in the beginning of this response was, were we going to have enough ventilators? So let's see the next slide. What's the difference? What's the difference with this virus versus others? I can tell you that, as I mentioned earlier, all ages are being affected. The nursing home population is the most vulnerable. As I mentioned earlier, 25% of the deaths have been reported in New York State have been in nursing homes. I put a note at the very top, and that note says, South Korea response was excellent. As I mentioned earlier, I was in South Korea. I was in Seoul during MERS. If you look at the literature and you look at the data from MERS, Middle East Respiratory Syndrome, they had an enormous failure of response, a failure in South Korea. I was working at the 121st Combat Hospital for the Army, and we had 0 cases of MERS on the base. And in the community, they were totally overwhelmed by it. They learned from that. The South Koreans learned from that. The response was excellent this time. And as you've heard on TV or being reported, that they had better testing. They did, because that's a better response. So that's why we need to get to better testing, and as facilities need to prepare for what are we going to do when this testing is really readily available all the time. It's not there yet. The PPE is not always readily available, or wasn't during this response. So that was something that we think was a little bit different, we can improve on. And then the guidance and response requirements were not well understood. Okay, so we understand that. I think we all understand that we could have had some better understanding of what to do. Maybe we didn't drill on this, maybe we didn't understand, but that with testing not being totally available is what has been different up to this point. Next slide, please. So today I wrote, over the weekend, I pulled this data up, so I apologize if the numbers are slightly off, but I wanted to put what the projections were for May 6th. And so we still know in the United States that the projected number of deaths per day is close to 700. Those are 700 that we, are being taxed with. So we're on the downward slide here, and if you look at this this graph, you'll see that we have past peaks of this initial peak, but we're on the downhill slide, but we hope that keeps going down. Next slide, please. It's the number of deaths. The number of deaths is expected to increase close to 90,000. At this point, we're at, based on this, 66,000. That might have changed over the weekend. And that yellow is uncertainty. So we don't know if that's going to keep increasing or if it's going to be declining. We don't expect it just to drop off to zero. So we still are taxed. In our groups, we were talking about pre-planning and recovery. One comment I made with some of my other colleagues is, what are we going to do about bodies, more, deaths that are going to continue to occur through June and July? We are already taxed for that, but what are we going to continue to do? Next slide, please. And then hospitalizations and resources are still being taxed. We have, depending on what part of the country you're in, limited beds, limited ICU beds, intensive care, and ventilator needs. So we're still not out of anything here. We're on the downward trend here, yes. But how do we recover from this? And so that's our next thought of how are we going to recover from this, but not let our guard down, because we may anticipate another surge of patients. And that's what all the literature has been showing, and all the organizations, including CMS, American Hospital Association, ASHE, where are we going to go from this? So next slide, please. So that's pretty much the history. We have some good models. If you haven't seen this, this is the American Hospital Association's COVID-19 models, very nicely done inside this document, which I'll provide to you, Len, or I can give, it's in the references at the end, some nice tools in there for looking at what's happening and some forecasting, very interesting. So I recommend that you look at that. The goal here today is to talk about where we have information for things for you to consider and what you should be considering. A lot of thought has been brought in, and everyone from the organizations that have published these documents have pretty much come up with the same conclusions that we have to worry about: staffing, PPE, space utilization, and then how we recover from that. Next, please. So CMS published over the last couple of weeks a document called Reopening America Again. Opening up America, and specifically for non-emergent, non-COVID-19 healthcare phase 1. And in that document, it talks about providing for adequate facilities. I recommend you look at this. This is the guidance that our hospitals have looked at, but more specifically, it addresses that you should consider the availability of staff. I know one of my colleagues is on the phone here from the Department of Health in New York, and we talk daily, or at least every couple days, and he's telling me that people are just totally exhausted. They're exhausted. One of our committees from ASHE, we talked about staffing, and when you bring staff and put them back into making sure that they understand what their roles are from this disaster response, how are we going to achieve that? How are we going to make sure that we don't have any bad outcomes for our patients because now we are switching our staff back? Are we going to have enough staff? Are we going to have resources for those staff members? Are we going to orient them right? And also occupational health. Facility considerations that CMS has mentioned, which is right on target, is that you need to continue with your social distancing. Visitors should be prohibited from hospitals if they haven't been pre-screened, and in unnecessary areas. And we should plan for normal operations as well as potential surges. Next. The ASHE guidance, we're rolling this out. It's on the ASHE COVID-19 resources. A lot of thought has gone on into this document. There's a number of sections, 6 different sections in there, where the group made up of different facility staff and experts. We talked about what some of the needs should be, and some of the needs that we specifically came up with are: how are you going to look at resources? How are you going to look at funding? What are some of the short-term needs, immediate needs, long-term? So I recommend that you take a look at that document on the ASHE site and look at some of the checklists that we came up with. And it's really just to make you think about what things you should consider over these periods of time. I wrote the short-term needs section, and specifically talked about staffing, how we're going to recommission our HVAC systems and our mechanical systems, mortuary and morgues, and then just some thought about other things that we should consider. Next. The group came up with some specific guidance as well as others. There's APIC and AIHA and other groups out there that are considering some of the shortcomings and things that we need to consider planning for a surge and have normal operations. That's pretty difficult. You know, if you're a hospital administrator and you're asked, okay, we're going to scale down here, but we need to be prepared for the same thing happening or at some phase of that happening or potentially happening, how are we going to do that? Occupational health guidance, we need better occupational health guidance as to screening for employees, providing, you know, behavioral health services for employees, increase infection control precautions. You know, as I mentioned earlier, we're seeing historically the same type of bacterial diseases and pneumonias that we've seen in our patients during these events in the past. We have now a lot of publication talking about detection of SARS-CoV-2 in feces, and we really are just looking at the big picture of aerosolization and procedures. The VA's put out some nice documented guidelines on how to deal with intubation, extubation. One of my colleagues she's made recommendations for like surgery centers. We're hoping to get surgery centers back up. That hasn't occurred yet. In some states it hasn't. And then staffing needs and resources and development of testing centers. That's worrisome to me because we planned for this in the past with our pandemic and our testing considerations. Where are we going to do this testing, and where in a facility are we going to achieve that? You know, it's just as important as where we're going to put these patients that were COVID-19 and isolate them. And then development of better contact tracing systems. That's something the South Korea CDC did very well. I put a reference document at the very end, and we can provide to you about an outbreak that they had, and they had very good contact tracing systems. That's something that we really were shortcoming on. We didn't have that as well defined or developed, and that needs to be done better going forward. Development of vaccination centers, where we're going to do these vaccinations once we have an approved vaccine, which will not be this year. It's almost impossible. It would be nice, but it won't be till the end of the year if you hear some of the experts in vaccinations talk about when that's going to be available. And need to rethink our response actions based on what we've had happen over the last 3-4 months. What can we do better? What we can do not to tax our staff and our facilities if this occurs at any level or phase that we've already experienced. Next, please. So some questions I've gotten, and I think we've all gotten, that's real important to think about. Will there be a second wave? What do you think? I can't tell you, no, there will not be a second wave, but history shows that there have been until we get that vaccine made available. We could hope that everyone social distances and wears masks, and if we had some testing and had a better way to isolate people, that second wave or that second surge or second virus event happens, that it'd be less than what we had in the first place. That would be nice, but we should anticipate that it could occur. What do we anticipate the long-term impacts to be? Well, that's a great question. The long-term impacts are facility needs, supplies, and where we store these supplies. We can have all the supplies we want. Talking to one of my colleagues the other day who's in the thick of all this, saying, well, what happens when we've got all these masks, and do we have a place to store them? What happens to our facility when we have all this influx, and what are the impacts? Those long-term impacts can be significant, we need to start planning for them and start analyzing them and see if there's something that we can do better or see what it's actually going to do to our facilities. Again, a lot of this is really geared after facilities and response activities and not just the clinical needs. What changes in infection control protocols are anticipated? Well, we've seen those change over the last few months. There's been interim guidance from the CDC back in March, which have changed slightly in April. As I mentioned earlier, we're concerned about aerosolization. Those have been significant changes in how we handle patients. We have guidance that says that we should not do anything other than emergent procedures because of the potential for aerosolization. So those infection control protocols are very important that we understand what they are and know what our guidance is from our state, local organizations. What are facilities doing with all the temporary equipment that was set up in surge sites? Well, they're not throwing it out. They're keeping it. They're planning to keep it. Where they're going to keep it, that needs to be considered and determined just in case we need it. Facilities in the past have had temporary equipment made available, but not to the extreme that we've seen over the last 2 or 3 months. So I don't anticipate anyone doing anything more than putting it to the side just in case we need it again, or yes, we will need it again, I believe. Next. What are, next slide. What kind of recovery efforts will be needed to utilize spaces for non-COVID-19 patients? Well, so if you have been overrun and your hospitals have been overrun, I worked ED for 15 years, and I can recall being in New York during the H1N1, and the ED was totally overwhelmed by H1N1 patients. These areas or spaces will need to be reevaluated. The recovery efforts that are going to be needed is look at utilization of space as you start to trend down as to your patients. Our guidance through our organization say you should look at that and decide how to reoccupy those patients. And in the guidelines, basically, don't put your guard down. If you're going to go back to normal operations, you still need to be prepared for the potential COVID patients that could come in. So non-COVID, we need to reassign those spaces. I would ask, what did you do now? If you had other patients coming in, did you actually have those spaces available now, or are you just going to convert them back? When we start non-elective surgeries, what kind of precautions are necessary? That's a very good question. The precautions are numerous. They are, everywhere from screening of the patients. I've had surgery centers ask, what if we can't screen our patients? Well, we should. These are non-elective surgery. We should screen our patients. The need for the need for N95 masks and use of precautions will continue. Cleaning continue. We need to make sure that we have good guidance, and that's specified. Do we need to disinfect the HVAC system in units converted back from COVID-19 units? I got this question quite often, and the answer is simply, well, no. HVAC systems don't, commonly get contaminated with virus. You may want to evaluate your system in the filtration system, but it's not a bacteria, it's a virus. It shouldn't live on these surfaces for any period of time. Our guidance from ASHE and ASHRE are basically to dilute the system, change filters if they look like they're discolored or dirty, and clean surfaces, and then follow the CDC guidelines for air changes and to remove particulate from the air. Next. So in summary, there's been a lot of recommendations. My number one recommendation is you look through these subject documentation to see what applies to your facility. there's been mention to need to have protective equipment available 90 to 120 days supply. That's a lot. I would love to have that. I think that would be good, just in case we have a shortage. But you need to consider what kind of personal protective equipment, what kind of strategies you're going to continue to implement. Don't just let it go away. Analyze and monitor supply and burn rate. The CDC has a very nice tool for looking at burn rate, which is the decrease in use, decrease of personal protective equipment based on use. So you can analyze that correctly. Our committee groups have continuously said you need to set up monitoring and analysis systems so that why this continues to occur, you can look at this information and see what your supply chain management processes are doing. Are they still effective? Review medication utilization, enforce social distancing, and then plan for facility needs as discussed in these guidelines. Those are some of our recommendations right now. You start looking at these and make determination where your shortages are. Next slide, please. Protect the nursing home population. I'm hoping that there are some people on here with nursing homes. I feel for the nursing homes. The nursing homes are vulnerable. The population is vulnerable. Our population, like any of these viruses, the elderly are the most vulnerable, and we're seeing the most deaths there. So we need to continue to follow these guidelines and continue to protect them and not put our guard down. Develop strategies for reoccupying these spaces and maintaining for surge capacity. Some hospitals in some states are requiring that you maintain no more than 70% of your capacity, which is good. I mean, I'm in Florida. In our winter months, we are really high capacity because we have a lot of people come to the state. This coming into the summer months, I don't know what we're going to see, but you need to look at what your capacity is so you can respond if there is an increase in infection. Monitor and educate staff continuously. We've heard over the last few months that staff aren't really understanding what needs to be done. The communication with staff has been not as good as it could have been. Develop better contact tracing methods, and then please plan for vaccination and testing centers in the future. The last slide, if you could put it on there, is for questions. After that, I have some reference materials that we've talked about. I think it's useful that you look at those. The CDC, the Appendix A air guidelines talks about those exchange rates. That's been out there for years. We use that as a benchmark to say, okay, we did this cleaning, we had this in this room, we need to do this many air changes based on our HVAC system. That coronavirus outbreak in a call center in South Korea, it's a good read. It recently came out, talks about how they did their response. As I mentioned, South Korea had a big increase in MERS, so they went back and re-looked at what they were doing. Reopening guidance for cleaning and disinfecting. I know a lot of those folks on the call were asking about what we do with disinfection and cleaning. I was in Seattle around March 15th when all this was starting to get hot and heavy, and was working for the Navy, and we started looking at some of the disinfecting and cleaning solutions that we had, and none of them were approved. None of them were really what we wanted based on the CDC guidance. CDC guidance has put out how to look and see what's approved for what we're dealing with, and this guidance that recently came out for reopening workplaces and businesses is very interesting. And then the interim infection control guidelines is what we're following right now. Next slide, please. And then the ASHE site, which has COVID-19, has a lot of these things that we mentioned, as well as the CMS guidelines that came out for hospitals. And then you need to go back to your individual states as well, New York, Florida, California, and see what those phases are for reoccupying and what some of the guidance is. I put these on my site under a link, all these references. You're welcome to look at them. If you can't find them, you should be able to find them there under this presentation. These are things that we just want you to start thinking about. Now's the time to do it while we have time to do it. We're just not going to stop and stop seeing patients, as you can see with the data. So let's take some questions if you have any.
So Bob, I'm going to first of all say thank you so much. Great information. And we do have a couple of questions that have come in. So I'll read those. If folks have additional questions as we're having these discussions, please feel free to type them into the chat box. So the first question we have is, Bob, do you believe that hospitals should take ownership of their local preparedness as we move forward, or should they continue to rely on national stockpiling? What have you seen? And maybe some of the facilities that are on the line can let us know what their feeling is.
If you have a hospital system, and there are hospital systems, or you have a county group, like in my county, in Hillsborough County, we have a very active emergency management group. All those hospitals talk together and they participate together. So if you're asking, should they take it on themselves for stockpiling, that's going to be totally up to that group. I'd recommend that you do have some local stockpiling of PPE, because not all facilities are going to have room for that. That's one thing that we addressed in committee is, what are you going to do about storage if you all of a sudden have somebody send you 1 million masks, which nobody would, but in a single hospital. So why not develop a more localized stockpile so you don't have to worry about that storage. The VA does that very well with their emergency stockpiles. That would probably be a good idea for local hospital groups to do as well. So yes, I would recommend that you get back to your local municipalities or emergency planning groups and see if that could be achieved.
Okay. And
I'm hearing from the different groups that they're worried about that. That's that one thing about, storage, where we're going to put this stuff.
You bet. Yeah. Thank you. And so we have a few other questions as well. And I agree. I mean, storage is always an issue, right? Never mind during a pandemic. So as we've learned more about the virus, which I'm not quite sure we really have learned all that much yet. I think there's still a lot to be learned. But have you been hearing that there are changes in how COVID is being treated? And if you have, does that then affect the need for beds, ventilators, et cetera?
Well, really don't have a treatment as of yet. What we are seeing is what we've seen in the past, historically, pneumonias and other for the patients that are on ventilators. So we get those ventilator-associated pneumonias or device-related pneumonias. We are seeing that, and we're seeing weird bacterial infections that are antibiotic resistant. We're seeing, as I mentioned earlier, the detection of COVID or SARS-CoV-2 in feces and others. So that might be a mode of transmission. For treatment, the treatments are all over the board. Some people are successful with some types, some aren't, but I really don't have a comment on that because there's really not an approved total treatment as of yet. We're still in the midst of that.
Evolving.
Yeah, it is evolving. This is, we're hoping in a couple months from now or sooner that we can talk about better protocols. People are working on it very hard, but the answer is I don't see anything that's been published or appropriate right now.
Got it. Thanks, Bob.
Great.
So I have a really great question from Octavio. I know, and I'm going to share my answer for this one. And Bob, if you've got something to add, please let me know, or maybe somebody else here has recommendations. This is a tough one. So what Octavio is asking is, what is the best way for manufacturers or for any of us to respectfully deal, approach and try to help facilities and the architectural designers without seeming like we're taking advantage of the pandemic? And I know that, everyone's nerves are on edge and everyone's really stressed. And I know I've heard from some of my friends and colleagues who work in the industry that there is, there has to be such a high level of sensitivity and awareness. And I think, Octavio, what I would tell you is it's going to be very individual, and we just have to proceed with empathy. And if anybody has, if Bob or anybody has any additional recommendations, I would encourage you to put them in the chat box. But it's just a really stressful time for everyone.
So your question is, what do we do with people that are recommending things just to be done that don't have any scientific basis?
Well,
or are there really false? There's fraudulent things going on, and we see that a lot during disasters, as you can imagine. And we discussed that, like, there's going to be people out there trying to sell you something that just doesn't really apply, or they're going to try, the junk science stuff. So you just got to do your due diligence, do your research, make sure that you say, hey, is this really feasible? Is this really supported by scientific data to be something that we want to do? And as for false claims and other things such as what we're seeing reported from people ordering PPE and not getting it because somebody fraudulently said they had it available, those are things that we hope don't happen, but they are.
Absolutely.
It's unfortunate.
Let's see. I guess there was some discussion in one of your slides previously, Bob, about reopening for elective surgeries. Mm-hmm. But somebody's asking for a clarification. This is Jeff. Hi, Jeff. Are you asking about, were you meaning to refer to non-elective surgery? The hip replacements, the knee replacements, and what do you see happening with the return to the elective versus non-elective?
So I put in there non-elective, and we're at emergent, and non-elective surgeries. The elective surgeries, yes, we are still not allowing, or we don't want to in some states. Or some of the others, they're looking at protocols as, if they're not emergent and they're not elective, do we really need to do those if they're not emergent? So that's what I was referring to. And there are protocols. So you could look and say, well, I need to have this done, but can I put it off? So that's what I was referring to. Yeah, and there are different protocols out there to address that as well. Yes, good question, Jeff. Yeah.
Jeff is saying he can give some perspective on this as someone that works at a hospital. So Jeff, would you unmute and share?
Hi, can everyone hear me?
Yes.
Sure.
I'm sorry, it's just the disembodied name in black and white on the screen there. My camera has been used so much it pooped out about 2 days ago. But from a sales perspective, one thing I would not do is send emails. Whether you're promoting a product or looking to reach out to somebody, we in the healthcare at the hospitals, we're getting really bombarded with emails every day for data updates at our local facilities. If we're in a health system, we're dealing with health system updates. So relying on email isn't the way to do it. Secondly, I wouldn't take an approach that this is an opportunity to expand your client base. The way that we're really reaching out to our consultants and vendors is the ones we have a good history to. We're doing a lot of fast deciding and fast movement. So supporting a hospital that way to help and facilitate some quick solutions is really the best way to support somebody right now. If you happen to have a product that's new and innovative, we of course want to hear about it. But again, doing it through sort of a normal marketing perspective isn't really the way. But really, again, approach your contacts to say, hey, we are here with solutions for specific problems, and make them aware a little differently, more as a partner than anything.
Yeah.
I agree with that, Jeff. About a month ago, I had people calling me saying, oh, I hear you're at the university and you're next infection control. I'd like to develop this product. And the problem with that is some of it was just really far-fetched. And we're going to hear that. And we have a lot of people that want to make solutions. We understand it. But we have to go back and look. Some of these products involved, tending the patient, making the room negative or not negative with the patient being in a certain atmosphere, other different types of devices. So again, as for your consultants, yes, you want to use somebody that you're familiar with, that you trust. You're going to have people trying to take advantage, but there's also, you have big hospital systems usually have good consultants that they can talk to and get advice.
Thank you both. I hope that's helpful, Octavio. Great. Okay. And so here's a question. Is there any logic to developing a scalable regional approach to dealing with COVID patients rather than the one-size-fits-all approach that we are currently seeing?
I guess there is. I mean, the response that we want to see based on the disease should be specific. When we first started seeing these COVID-19 patients come into hospitals, we automatically looked at our guidelines and our infection control guidelines for response. If we are specifically looking at this as a response activity and what we need to do, it would be reasonable to determine that that would be for those types of patients. Right now, as you mentioned earlier, we don't have the big picture. We know that it is a virus. We know that it lives on the surface. We know that we need to do precautions. We need to protect employees. And we do know we have some guidance as to how to contain those, patients. If there's no aerosolization, we put them in droplet precautions. If the aerosolization processes, we want negative air. How are we going to do this? So that would be specific for this type of response versus something else. Absolutely. Any other questions? Yeah.
Yeah. Any other questions, folks? Bob, this has been so helpful. And so I just want to say thank you, and thank you to everyone who has attended. And Bob, I know you mentioned, and everyone will get a PDF of the slides, as well as you'll have access to the recording under the members only page. If you have requests for other topics that we cover in these calls going forward, please feel free to email me. And if folks are interested, Bob, I know you mentioned that, a month from now, the overview that you would be able to provide might look very different. And so. Yeah.
The take home message again, and thanks for letting me talk to your group. We've been talking to a lot of different groups and talking to a lot of different people. Go and look at some of these references and see what you are missing. We hope in a month from now that we have a little bit different picture, that we can start looking at what some of our shortcomings have been over this response and make recommendations. But we're rolling this out. Again, ASHE's given some webinars on the next couple of weeks about some of the things we developed. There was a very nice document put out by the American Hospital Association, which looks at some of the similar things that we came up with. I was reading it before the presentation today. That seems the thing that we need to worry about is supply chain management, use of PPE, employee health, staff burnout, behavioral health, the workplace utilization, those type of things. So these are things that we need to consider. Please reach out to Lynn if you have questions, you know, and if you need something from me, if you need the references or whatever, reach out to Lynn or myself, and we just want to keep all going forward together on this and see what we can get done. Hopefully we have a better idea what our shortcomings are in the future. Nobody has been doing that right now because they're so overwhelmed. That's something that we need to work on.
And so, Bob, actually, could you speak to that a little bit? You mentioned that you'll be working on the after action reports.
Yeah, I've reached out to one of my colleagues in New York, and I think he's on the line as Mr. Montgomery, and I asked if we could start looking at together some of the shortcomings that some of the hospitals in New York, or all the hospitals in New York, are struggling with, so that we could do what we call an after action report early, or start gathering that information on the AAR. That's historically what we do during disasters. And we say, here's something that didn't work right. And what I talked to Jim about actually this morning was, if we could start gathering that information from all hospitals in your state and look at other hospitals as well, to see where some of those shortcomings were, and look for trends. Like, did 30% of the hospitals have a certain issue? Was it with staffing? Was it with supply, or whatever? What can we do? So that should be something that we hope to put out in the next, you know, couple months, have information, or sooner. But basically, that's something that we need to really look at. Yeah.
Yes, thank you, Jim. I was going to invite you to.
Okay, yeah, I'm still online. When I was a real man, I had a full head of hair, and I was a cop. You know, the one thing I always did was took, you know, copious notes all the time, no matter what was going on. I always took notes, and that's the one thing I always encourage the member hospitals to do. And it's not just you; it's everybody else. It's a mentality. Write things down. What went right? What didn't go so well? And then, you know, when we catch a breath a little later on, we get everybody in a room and we put it all together. We have everybody's attention right now. You know, having worked for the hospitals, you know, for many, many years, emergency management took a back seat because it didn't bring in a whole lot of money. But you could see when you don't prepare what happens. I mean, I remember after 9/11, we had rooms of ventilators and PPEs and everything you could imagine. But you know, that went away, and over the last decade or so, those things were not funded. So what happened was, all these PPEs and other things, they aged out and they disappeared. So then when this hit, look what happened. We're just struggling to find these things here. So this is our opportunity to get everybody's attention, to put it down, and then each area of opportunity, let's come to an agreement with the CEO and the exec team as to who's going to do it, how it's going to be done, what's the time frames, and how you're going to prove that it's been done. So you know, I hate to say don't don't lose an emergency here, but you know, let's take an opportunity to get their attention and make this thing work.
So actually, you raise a very good point, and I'm wondering, is there some framework for AARs? Is there some, you know, tool? Because that seems like an opportunity so that there's some standardization within the industry.
There absolutely is. FEMA has an excellent one. New York State Department of Health has another one. I'll share these things with Bob and he'll make them available, but they're a little redundant, but I have to tell you, it really focuses on what needs to be done and how it needs to be done. And you know, the thing is, you know, when I used to, you know, be part of a hospital, when a Joint Commission came in, they'd say, what happened over the last 3 years? Because it was a triannual, and I'd bring out my book, and they would read these after-action reports, because anything that happened, whether it was a drill or a real event, I had it broken down to AR. They took a look and they go, okay, everything that you had mentioned that you were going to do, you did, and you proved it. So yeah, that is out there.
That's awesome. That's a great story. Thank you so much. Well, we're a little bit past our time, but certainly very important discussions. So I do want to say thanks again, Bob, for being on the call. Thank you, Jim, for sharing. And I think Jeff has hung up now, but you know, to all of you who are on the front lines, we certainly do appreciate what you're doing for everyone's health And I wish you all health, you and your loved ones. And I look forward to talking with you all again soon. So that will conclude our call. Have a good day, everybody.
Great. Thanks, Lynn.
Thank you.